Hi everyone, my name's Jodie, Program Coordinator of Immunisation and Cancer Screening. So tonight I will be talking to you about our immunisation schedule to start with. So just wanted to bring to everyone's attention that obviously this changes roughly every 6 months when something new comes onto our program. Can we just all ensure that we have the latest version of this if we've printed it out in our practices? So the 23rd of April, this one in particular has actually changed several times. 1st of April, 13th of April, or a couple of dates. But so just ensure that if you are using the schedule and you have printed it out, that you've got the 23rd of April as being the one that you're showing everybody. So the changes that have been made since November last year was that Shingrix have been added and Zostavax has been removed. Influenza has been updated and Nirsevimab, or brand name Beyfortus, has been added. And these are all the things that we're going to be talking to you about tonight. And we'll also give you a brief overview of where we're sitting within our COVID space. So Shingrix. So as we know, shingles is a viral infection that causes a painful blistering rash. It's caused by reactivation of the same virus that causes chickenpox. And while most symptoms last up to 3 weeks, shingles can be very serious. It can lead to long-term nerve pain that can last for months and serious complications, including pneumonia, hearing problems, blindness, and swelling of the brain. About 1 in 3 people will get shingles in their lifetime. Shingles usually affects the older person, and the risk of complications also increases with age, particularly for those over the age of 70. People who are immunocompromised are at a higher risk of shingles and severe complications. So Shingrix is a non-live vaccine which is highly effective in the prevention of herpes zoster or shingles and its complications. As it's non-live, it can be used in immunocompromised people. It replaced Zostavax in November on the immunisation schedule. It's a 2-dose regime. The doses should be given 2 to 6 months apart, and both doses are important for the best coverage. The eligibility criteria for our immunisation schedule is as follows. So basically, people over the age of 65, Aboriginal people over the age of 50, and immunocompromised people over the age of 18. On top of the eligibility criteria, you need to be advised that if your patient has received a Zostavax under the National Immunisation Program, they must wait 5 years before they receive the Shingrix. However, if they paid for a Zostavax privately, they only need to wait 12 months. If the patient has had shingles, they should also wait 12 months unless they're immunocompromised, and then they can wait just 3 months. You can access the vaccine outside of the eligibility criteria at a private cost. So Shingrix is more reactogenic than its predecessor Zostavax. Headache, stomach and digestive complaints, muscle pain, body pain, redness and swelling at the injection site, plus tiredness, chills, fever, and injection site itching and generally feeling unwell are all quite common side effects. They usually last 1 to 3 days post-injection. And we just want you to make sure that you report those to WAVs just so that they've got an indicator of how people are going. Shingrix can be given at the same time as most other vaccines, including influenza and pneumococcal. However, it is best to give it by itself if it's possible. This can reduce the reactions experienced from having multiple vaccines, and you're going to know which vaccine it is that you've given that's caused the reaction. Now, you would have just received an email last week advising that we've now exhausted all of our current stock that we had of the Shingrix, but more is expected by late May, early June. I received confirmation this afternoon that there is now stock in the warehouse. Caps on orders are again in place until hopefully new stock arrives in the next week or so. Then we move on to COVID. So I've just popped up here on the slide our booster dose recommendations for ATAGI at present. So this just lists out for everybody whether or not a next dose or a booster dose is recommended and for what age groups. And that can be found on the ATAGI website. And I'm going to introduce you to Brooke McMahon, who is going to talk through everything COVID in our space.
Amazing. Thank you, Jodie. I'll just run over to my slide. So firstly, I'd like to introduce our team, the COVID vaccination team. It consists of myself, Brooke McMahon, and Rachel Brettig, who's a project officer. And we are now led by Jen Burns, who's our newly appointed activity lead. We also work very closely with Jodie and Adele to address some of the challenges faced by the most vulnerable in accessing vaccinations. So primary care providers have always been the central point of contact for vaccination in the community. However, it is evident that there are several known barriers for general practice and other primary vaccination providers in administering vaccinations in the home or in pop-up clinics. This includes the need for appropriate financial reimbursement, as well as the availability and capacity of suitably qualified workforce with the necessary program approvals. So we are soon going to introduce a new program called the COVID Primary Care Vaccination Support Program. And the initiatives in this program aim to offer time-limited funding for primary care providers to administer COVID vaccinations for vulnerable West Australians during the transition to business as usual vaccination models. And this funding is due to end in December, but we will find out more later in the year in regards to further funding. We also have our non-Medicare COVID vaccination reimbursement, which allows practices to claim the MBS equivalent fee for any patient that has had a COVID vaccination and is not eligible for Medicare. This slide has a link to claim to that. And we'll also make sure we provide the up-to-date COVID vaccination information and advice from the Department of Health to ATAGI. And on our slide, we do have a link to the latest advice. So now we've introduced ourselves, please keep an eye out on the WAFA newsletters and communications for further information on our program. And please reach out to us at gpvaccination@wafa.org.au if you have any questions or would like assistance, or if you have any plans that may help to increase rates of COVID vaccinations with your vulnerable community. Thank you, and I'll now hand over to Joe for his presentation. Thank you.
All right, hopefully you can all see my slides. So I'm one of the quality improvement coaches. Some of you in Perth Northwest might have already met me. I'm also an RN by trade, talking about the influenza vaccines available in WA. So we have a suite of influenza vaccines available. We have Vaxigrip Tetra, Fluarix Tetra, Flucelvax Quad, and Fluad Quad available, all through the National Immunisation Program. And they're intended to provide the vaccine coverage to children aged 6 months to 5 years, those medically at risk between 5 and 65, as per that table on the slides. And of course, the Fluad Quad, as we know, is exclusive to 65-plus-year-olds. As you'll notice, we've got Flucelvax, which is a new vaccine available and funded by the National Immunisation Program. And it's for those who are classed as medically at risk. It's a cell-based quadrivalent vaccine and has similar side effects as other flu vaccines. So it's just another option for patients who are medically at risk. And more information on these vaccines are available easily on the Australian Immunisation Handbook. Flu Quadri, as you can see, is funded through the WA Health Program, and it includes the cover for primary school children aged 5 to 11, people sleeping rough or living in overcrowded housing, and in the month of May and June for all people living in Western Australia between 12 and 65 years of age. All right, so the state-funded influenza vaccine program covers immunisation providers, both at general practice and community pharmacies, Aboriginal community-controlled health services, nurse practitioner clinics, corporate health services, and community health clinics, to administer to people who would otherwise not be eligible for a national immunisation program-funded vaccine. And of note, the state-funded influenza vaccines are funded for interstate and international visitors as well. Let me just... There we go. It's for interstate and international visitors as well, and also those without a Medicare card, which is really good news, as it means all people residing within the state have the potential to be covered with the vaccine. Conditions with the free vaccines, though, are that we are not to charge patients for the actual vaccine itself, and while we recommend that providers do not charge an administration fee, it's compulsory for community pharmacists not to charge an administration fee. As usual, all your vaccines are to be documented on AIR or AIR, and that includes the correct brand name, the dose number, and the batch number. And adverse events following immunisation, like discussed before, should still be reported through the WA VSS portal. It's also important to note that optimal protection against influenza occurs within 3 to 4 months following vaccination. So it's our role to look for opportunities to provide influenza vaccines to people during their visits to routine medical care, especially while those vaccines are free for all West Australians. And people who are planning international travel should ensure that they have that 2024 influenza vaccine before their departure. So just to touch on quality improvement very briefly, while influenza vaccines are something we provide to patients every year in general practice, we can actually document quality improvement activities around them. All activities that involve testing a change in how things are done. So with the intention of improving processes, the clinical management, and the patient or provider experience, they should all be documented in what's called a quality improvement register. And having this register is obviously not only important for practice accreditation purposes, but also so that all staff are aware of the changes that are being implemented at your practice. And if you're undertaking a larger activity that requires testing multiple cycles of change, you can use a template like a Plan, Do, Study, Act cycle or PDSA, and a local quality improvement coach can assist you with setting one up. So the AIR reports are a way that are an example of something that you can use for a quality improvement activity at your service, which as it involves reviewing and recalling patients for immunisations, which leads to improving population health outcomes. The 10A report is still available and helps you identify those that are due or overdue immunisations at your practice. The 42A report has changed slightly, and so now it's amalgamated to show those that are due for either COVID-19 or influenza vaccines, and it identifies both patients that have received an MVS service at the provider's practice but have not received vaccinations with that provider, as well as identifying individuals who've been previously vaccinated with that provider. And what you can do is measure your success by recording the number of patients you've recalled and vaccinated from those as a result of recalling patients from those reports. And that's how you record success in a QI activity. Another change in process this year is the ordering of influenza vaccines from the state-funded program. Now you can order directly through one link rather than in previous years where we've seen a reimbursement process. And like I said before, this is a change to a process, and so something you can document in the quality improvement register. And this slide here, I'm not going to read through it, but it's just for something to read in your own time, some other examples of quality improvement activities around influenza vaccines and how you'd measure their outcomes. And now I'd like to introduce Professor Pail Effler, who will be talking about RSV immunisation and the WA program.
Thanks very much, Joe. I'm going to share my slides hopefully here. Let me know if they're up.
Yeah, good to go, Paul.
All right, thank you. So I'm going to talk about the RSV infant immunization program that we've rolled out here since the 2nd of April. And previously, I've talked about some of the rationale and the overarching epidemiology and some of the effectiveness data that's been available internationally. So today, I'm really going to focus about how our program's going and what I think we need to do going forward, ultimately to even strengthen the program. Let's see if I can advance the slides. There we go. Because I am going to mention product or a product, Beyfortus, Nirsevimab. I'm just letting you know I have no stock holdings, no pharmaceutical affiliations, and no pharmaceutical payments that influence my comments. So just to refresh, we essentially have a 4-pronged rollout. We have a catch-up of all kids that were born on or after October 1st, 2023. So those children are all eligible to get Nirsevimab. We have a small group of kids entering their second RSV season who have particular medical risk factors that make them at high risk of hospitalization even in their second year, and they're eligible as well. We have all Aboriginal children entering their second RSV season, and I have the dates up there just the year prior, are eligible for Nirsevimab as well. And that is based on the data with hospitalizations showing that they have hospitalization rates akin to the some children with medical risk factors. And then we have what's just started on May 1st is our program in the birthing hospitals are everywhere children are delivered in hospital. They're to be offered Nirsevimab. The parents will be offered Nirsevimab before the child is discharged from the hospital. So how are we doing so far? As far as distribution, this is data from this morning. We have distributed 19,500 doses of nirsevimab in both strengths, the one for kids under 5 kilos and one for 5 kilos and above. That's a mix of those. And we still have about 8,000 doses in our warehouse. So this is likely to be enough to get us through the RSV season and to achieve rates as high as 80% coverage and or better. And why we think that's doable is that's what we've seen in European countries that have rolled it out in the last year. So how many doses have been administered to date? We have about 7,500 children that have been immunized with nirsevimab, and 830 different providers have entered at least one dose into AIR. So this is good uptake. It's higher than we get with than we have with our flu vaccines right now, for sure, in a slightly older cohort. And I'm pleased to see that so many providers have taken it up. So that suggests that we have the real capacity to deliver a lot of nirsevimab going forward. In the bars, what you see are the age where the children have received it, and given it's a program thus far focused on kids that are mostly 8 months and younger, that's exactly what you see. The median age there is 3.7 months. As we get more children immunized through the birthing program, we anticipate that will slide down a little further to the younger ages. So who's getting nirsevimab in WA right now? Well, not surprisingly, it's children in the catch-up season. The kids born on or after October 1st, 2023, because that's the huge numbers, right? The medically at risk and Aboriginal children entering their second season are small. And of course, the births are going to happen prospectively throughout RSV season. So not many have happened since May 1st. So that's what we would expect seeing. There are some people just looking at this in AIR. This is data pulled from AIR. Beyfortus is what we should be picking if we're administering nirsevimab, but we see that people are picking generic RSV, which we are assuming if they're giving it to kids this age, they mean nirsevimab and have not given them of actual vaccination, RSV vaccination, which is not approved in this age cohort. So just be sure that when you're picking your RSV immunization, you choose the right one. So trends over time, this is from the start of the rollout, the number of doses that have been administered according to AIR per day. What's good to see is our biggest weeks are our most recent weeks, and there's some data lag that occurs, so I'm not worried about this current week, which is not even finished. But we seem to be ramping up as far as uptake, and I think that's to be expected when people get used to it, have supply, and when parents are aware that it's ongoing. I do anticipate there'll be, I don't know if it'll be dramatic, but there will be some snowballing effect here going forward, which would be great. What about by jurisdiction, geographical area in Western Australia? Well, we can see all regions are running somewhere between 25 and 44%, but the wheat belt is the outlier in a good way, where they have significantly higher coverage has been achieved there. And we talked to some of their staff today about what they're doing, and they really stress that they're doing recall, sending text messages to remind people and making sure that they're aware it's available and setting up appointments. And also when they see young children in the well baby checks, they're asking about whether they've already had it or not and making arrangements for them to get nirsevimab if they haven't already. So how can we improve our coverage? This is good. 7,500 is essentially about 280 infant hospitalizations that have been prevented. And I'll close by showing you data from Europe that leads me to believe that. So I love the fact that we've probably prevented nearly 300 infant hospitalizations from occurring this winter. But we can certainly do better because we have supply and we have kids out there who haven't been immunized. And one of the things I think we need to improve on is the missed opportunities to co-administer nirsevimab when a child is getting another immunization. And why I say this is we have the ability to look at error and identify kids that were born on or after October 1st, 2023, that have another immunization visit, another encounter recorded in error, and see whether they got nirsevimab at the same time. And so going back to the beginning of the program, when we look at that, there's been almost 13, well, there's been slightly more than 13,000 visits. And during this time, slightly less than half had nirsevimab administered at that vaccination visit, essentially. So kind of a missed opportunity. Certainly parents may say no if there's additional jabs, but when we break this down, well, that turns out it's almost 6,500 missed opportunities. When we break this down, did these children get like 4 other jabs or 3 other jabs, and that's why the parents didn't want to go for nirsevimab? Well, what we see is, in fact, 90% of the children who had a vaccination visit but didn't get nirsevimab had 2 or fewer other injections at that visit. And we are counting rotavirus as in this because it's not a needle injection, so we don't think that's likely to influence parental decision making. So nirsevimab, for 90% of these kids, nirsevimab would have been their 3rd jab, and certainly that is doable and standard practice in vaccination clinics here and around the world. So, but the upside is you do see that a lot of providers are administering nirsevimab to children that had 2 other jabs, and that tells you that parents are probably, at least some parents are certainly open to it, and some providers have no issues with doing it. Recently, I asked the crew here, our excellent data team, to break down the data, and let's look at the more recent weeks. So basically from the 1st of May to the 14th of May, to see if we're getting better at this, and break it down by GP practices versus child and community health nurse practices. And what we see there is actually that GPs have gotten a little better. They're up to more than half in the last 2 weeks co-administering at 52%. But child and adolescent community health nurses in the country and metro are actually doing much better. They're co-administering at 2/3 of the time, 66%. So we'd really like to see other practices get to the level that community and child health clinics are doing with co-administration, and even have more co-administration go on at our government clinics as well. So we can get these kids protected before RSV season takes off in earnest. It will likely be sometime this month. Based on history, it will happen sometime in May. If not, it'll be early June for sure. So we have a little bit of time still left. All right, so what else can we do besides reducing co-administration? We can make parents aware that it's available. We have heard still that there are parents that are presenting who for other vaccinations, and then they are asked about nirsevimab and they say, I haven't heard of that. I need to think about that, and go away. So we're trying to generate as much media as we possibly can to let people know that it's available and ask them to inquire with their providers. In fact, recently, over the last several days, we have had the chief health officer sent a letter to every mother that's registered in the midwife's notification system that had a child born on or after October 1st, 2023. And this letter lets them know that nirsevimab is available and the benefits, and to talk to their provider. So we're hoping that will generate some interest. Just today, I wrote a briefing note and modified the letters because we'd like to send these out prospectively to new mothers to say that if your child didn't get it in the hospital before discharge, it is available still for that child in a primary care setting, and giving them advice on how to seek that. We're also aware that at least child and adolescent health clinics and WA Country Health Service clinics and private providers are sending out text reminders to their clients, and we're hoping that will generate interest and appointments. And then I think we got to improve data capture, because I actually think some of the lower rates, particularly in the newborns that we're seeing thus far, is due to inability to capture data comprehensively. And why I say that is we know the number of doses we've shipped to birthing centers and the reorders that they've had, And also the doses that are in air are much lower than the consent forms that we are receiving, completed consent forms for nirsevimab for those same institutions. So clearly there's a disconnect there as far as timely capture of the data, I'll say, because maybe it's still coming. And we're working to try and figure out that puzzle and going to be reaching out to the birthing hospitals to really iron out what they're doing and how we can capture that. And I will say one positive note is I was speaking to endorsed midwives today, doing a webinar for them, and one of them said they were up on the labor ward at King Eddie and talking to the staff, and they were hearing that the acceptance rate is exceedingly high and that it's going well. So that it was reassuring to me that probably we do have a data capture problem rather than a parental acceptance of RSV immunization. So I mentioned that we're not in RSV transmission season yet, and this is why I say that. We've created a dashboard that's weekly, pulls data about the number of lab confirmed RSV cases that have been notified, breaks it down by age group, and identifies whether there's been a hospitalization associated with that individual in our databases. So this will enable us to track both the incidence of RSV and the hospitalizations across age groups, as was done in Spain, so that they could see the impact of nirsevimab in real time. And yeah, so the red line there, the previous two seasons are blue and gray, and the red line there is this current season. So the good news is, even though we're not at the levels I want to be, we have a little bit of time here, I think, before the threat of RSV sweeping through the community is even greater. And lastly, I want to close with some data which I find very impressive. And I've talked about Galicia, Spain before. There's actually been 3 studies that have come out of Spain, but this one is is analogous to the program that we've done with a catch-up program and a birthing hospital program. It's now not just on our website as unreviewed data. This is published in the Lancet. I think it was less than 2 weeks ago, April 30th, so 2 weeks ago. And it describes their experience and the initial impact of using nirsevimab there. And essentially what they found, they got 92% of eligible infants immunized. And that includes the catch-up cohort and their birthing cohort. So that's a phenomenal accomplishment for them. And it likely reflects a strong public health system in Spain. The effectiveness of nirsevimab was 82% against hospitalization for RSV associated lower respiratory tract infection, which is just like, it was 80% in the clinical trials, and other places have reported about 85%, with the US reporting 90% in their setting. So a convergence of the evidence on 80% or better, and I feel we can use that pretty comfortably. It was 87% effective against the hospitalization requiring oxygen support, so more severe illness. And again, another place in Spain has reported 90% effective against RSV ICU admission, so very similar. And effectiveness was 66% against all-cause hospitalizations in this age group. And how could it do that? Well, that's because RSV causes so many hospitalizations in this age group. So it really can impact the burden on our healthcare system. And hopefully, Perth Children's Hospital will get a break this winter and be able to devote their resources to taking care of other patients, because we've prevented infant hospitalizations. So they reported no adverse events in their study of the kids that were immunized. But this is the most important thing, I think, to impress upon people. The number needed to immunize to avoid one RSV-related hospitalization was 25. So for every 25 doses, they prevented an infant from being hospitalized. And that's just remarkable. I mean, I haven't worked with the immunization product that's this effective. And it's probably because most of the vaccine preventable diseases through vaccination, we've really suppressed them and nearly eradicated them if you're looking at measles. But I just want to impress upon the WA's providers that we have a real opportunity here to cut down on hospitalizations of young infants, and it won't take much for all of us to, for practices to prevent one in their very own setting. So with that, I'll close and take any questions, and thank you very much for your interest in keeping kids out of the hospital with RSV.